You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, everybody, and welcome to another episode of CRST, the podcast. In this episode, we're diving into presbyopia correction from drops to devices. I'm Kathy McCabe, Chief Medical Editor of CRST, and I'm joined by 5 individuals from across the United States who come to the table with different perspectives and practice patterns on presbyopia correction. My comrades for this discussion include Brian Schaefer, Mitch Schultz, Stephen Slade, Audrey Talley-Rostov, and Dagny Zhu. All of us on the panel have experience with a variety of presbyopia correction methods, but I'm sure that our preferred treatments and thoughts on patient selection all vary a bit. Let's jump right in by talking about the newest presbyopia treatment on the block, and that is pharmacologic agents. Right now, the only available presbyopia drop is Vuity, but others are on the way. So let's just start it off by saying, I always like to start a presbyopia discussion by first finding out who on the panel is presbyopic. Anybody willing to admit it?
Oh, come on. I'm the only one.
You are not. No, first let me say, as a revelation, I am fully 100% in the depths of presbyopia. So I'll kick it off, Steve, with that admission.
I'm also fully enjoying my presbyopia to the max.
Are you enjoying or enduring? That's what I wonder.
Mostly enduring.
All right. So the 3 of us, so this is good because we have the 3 who are just, really kind of organically and very emotionally, maybe even understanding the struggles that our patients have. And then we've got our 2 younger, very enthusiastic, yet very experienced docs here who are going to tell us, how they approach it from their point of view with their patients, knowing that this is going to happen to you too. It will. It's on the, it's on the horizon for you as well. Maybe far on the horizon, but it's there. So anybody here already prescribing Vuity? Who's already had patients that they've prescribed or maybe even experienced it themselves?
Well, okay. I have prescribed it. We have prescribed it from the office. I use monovision, which I think is a wonderful tool for presbyopia, and I don't even own glasses readers at all. So I have not used it myself, but I have experimented on my wife with it. So we've become familiar with it.
And how about you, Audrey? Have you used it, prescribed it?
I'm with Steve. I also do monovision, and I mostly like it. I actually, for operating, I put on glasses, but mostly I'm okay with my monovision. I have tried Vuity on my husband, so I guess we are in the.
I'll be the trifecta here because I also use a combination of mini monovision and multifocal contact lenses, and I have tried it on my spouse as well.
They all deserved it.
They deserve it. They do. All the best.
I was just saying, my husband, his brain can't do monovision. It might be a multitasking thing too, but he can't do monovision. And so we've been experimenting with a little bit of Vuity.
And what was his experience with it?
He said that it stung when he put it in. And I don't know if he thought it made a big difference. I thought it made somewhat of a difference, I would say. And so I wouldn't call it a huge success, but I'd call it maybe a mild success.
Mm-hmm. And Steve, your wife as well?
She liked it okay, but the same thing, it stings and it's temporary. So you kind of ride it up and then you ride it down as it fades away. So not a complete success, no.
I'm going to chime in here, and it's thank you, Kathy, for inviting all of us here tonight to discuss this. It's a great topic. With regards to Vuity, I actually have prescribed it, and I prescribe it on a weekly basis for patients. I've found it to, there definitely is a pool of patients that are interested in not wanting to wear reading glasses, especially some of the younger presbyopes that aren't used to it and just don't like putting them on. And it's, and I think if you choose the right patients, you can have happy patients is the bottom line.
Yeah, so have you yourself, I'm not trying to imply that you're presbyopic, but myself, I am, and, have you tried it on yourself?
I actually have, and what I'm going to say is I don't use it on a daily basis. I had LASIK. It's kind of hard to believe that it is now, 26 years ago. So that will tell a little bit about my age. And with my LASIK, I have had a little bit of regression. So I have some uncorrected astigmatism, a little bit of myopia. So on a day-to-day basis, I don't actually need the drops every day. I can actually function in the office without glasses. However, when I get into situations where where there's low light and difficulty in seeing printed, things like menus, even looking at books, or true printed objects where I can't just take a screen and zoom and pull it wider and brighter. I definitely will put Vuity in my eye. So I found it helps me in a couple different ways. So number one, being post-refractive and having a little bit of residual astigmatism, the uh, the pupil constriction effect of the Vuity, or the pupil management effect of the Vuity, actually helps to eliminate some of my astigmatism. So for night driving, it actually kind of helps me. I find that I actually do see a little bit clearer at distance as well as at near, just from the control of the pupil effect, where we're getting to I'm going to say for me, it's probably, if I look in the mirror, it's kind of like a 2 millimeter, somewhere between 2 and 3 millimeter pupil size, which really does help to eliminate some of the aberrations from that. But I actually have found, even at this, I'm 56 now, and I do find that it does help with my near vision. I'm able to function for probably anywhere from 4 to 5 hours, I would say, without glasses, to pretty much see every size print with that.
Yeah. Okay, so Dagny and Brian, I'm sure, you may have had experience with patients, maybe family members yourselves, and Vuity. And do you have any pearls as far as prescribing, or maybe patient selection, or feedback you've heard from patients? Let's start with Dagny.
So I'm fortunate to work in a fairly busy refractive practice where I have patients coming in every day asking to be glasses free. And so I probably see 5 to 10 good candidates for Vuity a week. They're early presbyopes and they're not ready for surgery. And I personally don't feel comfortable doing a lens exchange and an emmetrope when their lens is still functioning, partially at least. And a lot of them don't tolerate monovision because they've had perfect vision all their lives. And so those are the patients that I've tried Vuity in. And I have to say that, I get like a variable response. For some patients, you don't see any improvement, but then quite a few you get really surprised. So I've dropped them in the chair, and 15 minutes later, I'll recheck their near vision. And so I've seen patients go from even J10 to J1 in 15 minutes, and I've been pretty surprised. But typically I find that it works best in patients who are on the younger side, in their early 40s. They're really mild presbyopes, maybe J3, and it gets them to a sharper J1, sometimes even J1 plus. And so those are the patients that I typically aim for, although occasionally you will get the older patient who has a remarkable response. But pretty much, I don't really use age as a marker. I use lens function. So if they still have partial accommodation with their distance correction, they can get to J3 around there. I feel like Vuity might work well. And so I'm more motivated to try it in those patients.
And Brian, anything different that you're doing with your patients?
The biggest thing that I'm doing with my patients is having a really hard time figuring out how to use Presby drops. And part of this is completely my fault because there's a couple things I'm passionate about. And one of those is getting people out of glasses. And the other thing is getting people off of eye drops. So Presby drops are kind of the perfectly opposite confluent interest to me. But it does seem to have its place. And as a ophthalmologist who's seeing patients and seeing surgical evaluations, I'm having a hard time really figuring out how to talk to the patients about it. We know that the patients that do best give it a good 2-week trial before deciding if they like it or not. It's almost like getting a new pair of glasses. You have to give the patient time to adjust to those glasses. The same thing is the case with pilocarpine, and we saw it with old glaucoma patients, and we're seeing it again with Vuity, where the first 2 weeks they say what Steve and Audrey said, it stings. Some patients are saying they get a little bit of dimness. And one of my practice administrators who tried it on herself, she kind of described that sensation you get if you get off of a cruise ship and you still feel like you're on the water.
Mm-hmm.
And those 2 weeks are the adjustment period. And as an ophthalmologist who is trying to get people out of glasses and off of eye drops, how do you actually guide them through that journey? And that's been my challenge. I don't know if you guys have had similar experiences.
Yeah, I'm going to say that in my patient population, kind of a little bit of what you've all said, that, might be a little stinging. That really has not been a barrier. I've had a few patients with a headache, and then this sort of difficult to describe sensation. Some people call it feeling dizzy, or I've heard somebody say it feels like they're in a movie, or everything's pixelated, or there is a little neuroadaptive part that happens in the early experience. So I totally agree with you, Brian. It's not a one day, trial really to get to have success. But there are patients, and sometimes patients that surprise me because they're older than I think they would be, to have a really great success, who just love it and think it's life-changing for them. And there are other patients who think it's really great for certain circumstances, certain times that they want to be more glasses independent, but maybe not every single day. And then there's patients who I think would be a slam dunk. They're younger patients. They don't have a great need for a lot of increase in their near vision, and they just don't really respond. So I think we're still learning a lot about this drop. Coming back to you, Mitch, who do you have a special patient profile where you go, oh, this patient, I think they're really going to benefit from a pharmacologic treatment? Who would you say are your kind of go-to patient for that?
Well, certainly I think pretty much all early presbyopes are good candidates. I think the key is really, I do look at what the total plus prescription is. So including their uncorrected refractive error, if they're a hyperope particularly, I kind of want to know what their uncorrected plus spherical equivalent is. And then I know that we can, in essence, treat patients for, let's say, up to about 2 diopters of, 2.5 diopters of total hyperopic correction. So, if they're a low hyperope and they're young, and we know that their presbyopic demand is, in that range, then it's a drop I'm going to offer them. If they're a low myope, I can actually go a little further, so they can be a little bit older, like myself. Being about a minus 0.75 spherical equivalent, and even though I'm a 225 ad, my effective ad is really 150 when I'm uncorrected. So therefore, I fall in that range. So it's looking at the total refractive error, adding their uncorrected error as well as their presbyopic demand. And if you look at that number, I think as long as they fall under about 2 diopters, 2.5 diopters max of total plus prescription, you're going to have happy patients. And I actually apply that principle not only to phakic patients, but to pseudophakic patients as well. So we have plenty of pseudophakic patients that we've operated on previously that didn't have options for presbyopic lens implants, or even those patients that couldn't necessarily afford a presbyopic implant, or even patients that have presbyopic implants. We can actually utilize this drug. So it's been very interesting to kind of get a feel for all the different patients that we can actually treat with this medication.
Yeah, I've had a similar experience as well. And I think that we're really finding out where those sweet spots are. And sometimes it's not the patient you expect. It's just sort of a, hey, you know what? We have another tool. Let's try this and really have a great result. So I love hearing everybody's individual stories about that and how we can fit these drops in. Do any of you use it as a more of a maybe a diagnostic thing, maybe in more complex corneas, or if you're thinking of other treatments you may use in the future, like a small aperture inlay, or not inlay, but intraocular lens? Do you think there's a role for it with that as kind of diagnostically or predictive of how a patient might do with different technology like the small aperture IOL?
There's a place for it for aberrated corneas. because we know with, pinhole optics, you're filtering out those peripherally scattered rays. And so when you bring down the pupil, you're able to create a much sharper image. And so patients who've complained of long-term halos and glare after LASIK, or those who may have corneal scars or keratoconus, those are definitely patients that would be ideal for a pupil modulating drop and potentially the IC8 small aperture lens in the future. I've used it mostly for my patients who've experienced kind of dysphotopsias, halos and glare after either LASIK or a multifocal lens. So I've tried the Vuity in those cases. And I think it works well. I actually used to even use regular pilocarpine 1% for those patients who just needed something to help them get through those, bright lights from cars when they're driving at night. And I do feel like it has a good effect. And compared to generic pilo, I feel like it's much more tolerable. I don't have the same proportion of patients complaining about headache. In fact, for me, headache hasn't really been a huge issue in the patients I've tried Vuity on. Whereas with generic pilocarpine, headache was the main issue, and a lot of my patients just could not continue the treatment for that reason.
Yeah, I agree that I haven't seen a lot of patients with headache either. And I've had some real successes in patients with either dysphotopsias or patients who I just didn't think that they were getting the quality of vision because of a complex cornea, that they might have had a couple real wins in that regard. Again, there's the duration of action issue that I think maybe some different formulations coming out might have longer duration of action. So that's exciting to think that that might be on the horizon as well. And any other pearls for using or trying these drops? Do you see any role in that sort of thing for your patients as well, Steve, for instance?
No, I mean, I think the main thing is diagnostic. But when I look at these drops, again, they're all temporary. And again, the measure for success is certainly what the patients think. But then
Yes.
number two is what we think. Do we think? And what I want from them is something that would be a bridge to keep patients in the practice from the LASIK age to the cataract age, from the 40s, 30s, into 60s, 70s. And I'm not sure that they are going to provide that. I don't think that they're going to tie patients to the practice. I think they're more, you prescribe them, if the patient likes them, great. But then they'll probably go elsewhere that's easier to get the prescription for it. Or I just don't know if they have enough to do that, to be the bridge procedure that I want.
And what do you think? I'm sure you're seeing a lot of patients, particularly in your practice, that have had LASIK and now coming back to you, doing great at distance, but presbyopic, and hoping that LASIK's going to really be that solution. Do you think that if you had a longer acting presbyopia correcting drop, you might be able to bridge the gap between this LASIK patient who's now presbyopic and a lens exchange procedure, or do you think you're still going to, more quickly go to lens
I think
exchange?
you're right. No, I think you're right. I think, a long acting would work, but I mean, like long acting, like LASIK was long acting, or
Right.
IOL is long acting. I just don't. There's been so many attempts to try to come up with something, but even when we look at all the different ways that they use radiotherapy and heat to reform the cornea, those only lasted. I mean, those would last for several years, but they weren't successful. I'm just not sure it's going to pass a real world test as a temporary treatment.
I think of it more as like a kind of a temporary, almost like a cosmetic use of it. So where someone likes to go out maybe to dinner and see if they can not use the reading glasses as a temporary thing because they know that it doesn't last very long, or somebody who had, as you said, Kathy, had LASIK and is looking for just a little more oomph at near, at least for a short period of time, knowing that there is going to be a period of time where most likely they're into reading glasses or some sort of monovision between when their LASIK, as they say, wears off and it's appropriate for a lens exchange. So I think that, lens exchange, depending, of course, on the age of the patient and what the other comorbidities potentially of their eyes, I think is a really nice way of addressing presbyopia.
I kind of see it as a post-surgical adjunct too. As some of you have already mentioned, in those patients who need a little oomph, like Audrey said, it's almost like a rescue drop. Those patients who've had a multifocal lens or an EDOF lens and they're not getting as much near as they want, or for those LASIK patients who maybe you don't want to can't tolerate full monovision, but you could do a little mini mono plus the Vuity. So it's almost like an adjunct with surgery where it gives you a little bit extra near and that little oomph. So I feel like there's going to be more applications in sort of surgical eyes, even more so than virgin eyes in some cases.
Yeah, I like that approach or thought process too. I have one of my happiest patients on Vuity actually had crystallines and really just wanted more near. And it actually improved her distance to some degree too. She had a little residual astigmatism. So I think you're right that a little extra oomph, even in those patients who are post-surgical, either with IOLs or LASIK, I think, or even monovision, as you suggested, it could be a great adjunct, especially as we have other formulations to look at in the future. We know there's a lot of other drops coming out on the market too. And what do you think are going to be some of the differentiators between the different drop categories as they come out? How are we going to think about these drops once we have more than one to offer?
Well, again, I think there are multiple factors. So, some of the medications that we're using, so that we're looking at drops. I think duration of action, I think, is going to be a huge issue. So, as we have some of the newer products available that have longer duration of action, I think that will be a significant factor for patients because, number one, nobody either wants to think about it or wants to have to worry about carrying bottles around or even carrying disposable drops around with them, and they don't want to go through a period where they're seeing well and then all of a sudden they're not seeing well and then they have to put another drop in to see well again. So I do think duration of action is going to probably be the largest differentiator as the market matures.
Do you think, when I'm thinking about duration of action, sometimes I think, well, there are going to be circumstances where patients want a shorter duration of action too, because maybe they have to do something, at night and they really do find a dimming effect if it's persistent. So I think you're right. I totally agree that'll be a differentiator.
Yeah, I mean, that's a really great observation. There are some patients, certainly when we first got our hands on this drop and, it was hard to come by and I was kind of giving it out like gold to friends and things like that. But hearing the feedback, so, the patients that we see, we don't really get the feedback necessarily because we give them the prescription and we send them out and then we may not see them for 6 months or a year even. I don't bring the patients back to see how they're doing on Vuity. However, my family members and friends and things like that, where I do see them on a regular basis, I've been able to get feedback from them to kind of gauge. Some of them, definitely have experienced the dimming effect and don't feel real comfortable with it. And others like myself, I kind of noticed the dimming effect when I first put the drops in, but then it seems to go away, and I think my brain just kind of is okay with it. But more than that, because when I don't wear glasses when I'm driving at nighttime, I don't see that great. I mean, fortunately I have a electric vehicle with a really big screen that allows me to kind of know where I'm at. But short of that, actually looking at the streets and things like that, I do find it's a little bit more challenging because I can't see the license plates or the street signs aren't as sharp. But when I use Vuity, even though I have a little dimming effect, everything else is so much clearer that it kind of reminds me of when I had my LASIK originally. So I definitely, I personally like that effect, but I can certainly see that being an issue for some people who would kind of like it to wear off as they leave work as well.
But let's shift gears a little bit. And since we have been talking about lens options, let's dive a little bit deeper into that as well. So many patients with presbyopia are good candidates for IOL surgery. And although our colleagues in Europe now have many more IOLs to choose from than we do here in the US, we can always look on and see what we may have in the future. But even here, options are growing. We have lots of choices. So with the array of choices we have in the US, and even what we know is on the near future, kind of some of the newer approaches with monovision and maybe some monofocal plus and other solutions, let's just go around the whole table here and virtual table and see what your current go-to IOLs are for patients with presbyopia who really want that expanded range of vision. So we have lots of options. How about we're going to go in reverse order now. We'll start with you, Dagny, and tell us what's your go-to.
So my go-to presbyopia correcting lenses would have to be the PanOptix and the Vivity. Oftentimes, sometimes mix and match. So I use the PanOptix in the non-dominant eye and the Vivity in the dominant eye. And I actually do that mix and match in the majority of my cases now. And then the rest of my cases will either be bilateral PanOptix or bilateral Vivity, depending on their needs and the amount that they drive at night, and different features related to their quality of vision at distance and nighttime mostly.
So do you find that issue of glare and halos at night or the possibility of dysphotopsias is one of your driving factors for Vuity versus a trifocal like PanOptix? Or is it sometimes also early pathology within the eye, or is it kind of both?
Oh, it's definitely both. Vivity has filled a tremendous gap, I think, in all of our practices where we have patients who desire presbyopia correction, but they're not good candidates either because objectively they have mild pathology somewhere, or they don't tolerate the halos and glare because they drive, very often at nighttime, like truck drivers. I have a lot of those patients. And so those patients, I may have previously done monovision with a monofocal lens, but now I have the Vivity lens in which I can just target plano or even do a mini mono to give them a little more near. And so it fills a very nice gap and it offers presbyopia correction to more patients than ever before. And so I do it for both of those reasons. And I find that combining it with the PanOptix actually gives me the best of both worlds. I presented at ASCRS this year my results on the mix and match PanOptix and Vivity, and found that the satisfaction was very high, over 90%, and most patients were spectacle independent. Almost 90% were spectacle independent completely, including at near. And so it provides just enough near, and also they really don't notice, the majority did not notice any dysphotopsias at night, which was actually far better than I had expected and better than my data with bilateral PanOptix.
Awesome. That's great. How about you, Brian? Any difference in your approach? What are your sort of go-to IOL choices?
I'm very interested in everything that Dagny just said there. It could shift my practice a little bit, but what I've found myself shifting to over the past couple of months is shifting away from diffractive technology. And I don't know if it's just specific to my patient population. I practice in an affluent area in the Philadelphia area, but the dysphotopsias are very real. And although most patients do adapt and feel completely fine about them, it only takes a couple before I see my own pattern shifting. And I've really been getting a lot of mileage out of Vivity lately. So that's undoubtedly my go-to presbyopia correcting lens, even though it's not going to give the full range of spectacle independence. I find myself more comfortable knowing that this patient, even if they go on to develop some sort of retinopathy in the future, maculopathy, I know that that lens is still going to give them most of its benefit or its full benefit, rather than if they were to have a diffractive lens in their eye. The other thing that I have been doing to some success is in patients, particularly low myopes who are so used to taking off their glasses, I've been doing bilateral Vivity targeting -1. And with targeting -1, they're 20/40-ish at distance and J1 up close. And before Vivity, we didn't really have the opportunity to do this with any extended depth of focus lens because there was just too much noise because there was at least some component of diffraction. But with Vivity, there's not that added noise because it's just the X-wave extended range. It's not really true diffraction. So I've had a lot of good success with that, and patients are extremely happy. These low myopes who their whole lives walk around the house without glasses anyway, and they're used to that distance blur and just popping on a pair of distance glasses. So I've really shifted to focusing on the near even more than the distance sometimes.
I think that's very interesting. In those patients, I would consider, being closer to plano in their dominant eye. So I think it's interesting that they tolerate that well, and that strategy has worked so well for you. So I think it's really very, very informative for us to hear how we're all sort of integrating things. So Audrey, go ahead and tell us, what are your IOL choices and how do you decide what to offer patients?
Sure. I use a number of different IOLs, and I really like to match the technology for each patient. For example, I pay close attention to the higher order aberrations. And if someone has significant higher order aberrations, then they are not going to be a candidate for a multifocal type IOL. I would consider putting in a Vivity in that patient. And so I have had a lot of success with those patients with Vivity, and I target a mini monovision. I target about a -1/4 in the dominant eye and about a -1/2 in the non-dominant eye. If somebody's higher order aberrations are minimal, then I will do either a Panoptics or the Synergy IOL. I find that the Synergy, although there is glare and halos there, as there is with the Panoptics, it gives a little more pop at near than the Panoptics. And so again, I have a discussion with the patient and really discover what it is that they want to do and need to do. And if, for example, I have a few lawyers who really wanted a lot more pop at near, they understood that they would have glare and halos at night. And actually, one of my husband's friends, who's a lawyer, says that everyone looks like an angel at night, right, because of the halos. But that he loves being glasses independent. I also use the LAL, and for anybody who's had previous LASIK or RK, my go-to lens right now is the light adjustable lens, again, targeting a little bit of mini monovision. And, it is adjustable. You've got essentially 4 shots on goal there. And I find that patients are very, very happy there with the light adjustable lens because you are getting that extended depth of focus. And so for me, I don't just have one lens. I also, as Dagny does, I also do some mix and match. I actually did a couple of cases today where they had a Panoptics in one eye, and I put in a Vivity in their other eye. And so I really use all of the different technologies, and I try to make it the correct technology, matching it for each patient.
Yeah, I love that we have so many choices, so we can really, drill down. Even after the first eye is implanted with one lens, we can assess how the patient's responding and what their residual refractive needs are, or where they're still seeing a deficit, and fill in the blank, so to speak, with technology with their other eye. And we're going to come back to light adjustable lens, but I first want to hear from Steve. What are you doing in your practice?
Well, love the different choices, and that's really become our job, hasn't it? To figure out which lens for which patient. Panoptics is what we use the most. I am very excited about the results with Panoptics. It's also fascinating how different opinions we have. We used a lot of Vivities and we don't anymore because we were taking them out. It's not the number of good cases, it's the number of bad cases. And our explant rate with Vivity was just too high. We use second most, we'll use LALs, and all the good things that have been said about them, I agree with. They're so powerful. What I wish we had was a better lens for people that maybe have a little bit of, the hyperopic LASIKs, maybe a little bit of compromise in their corneas. I thought the Symphony was terrific for that. They're coming out with a new symphony that we're going to be using soon, and I hope that will work. But yeah, just 2 or 3 years ago, one of my friends in Europe said, when we were all using restores and bifocals, he said, we just threw all those out, and now we use trifocals, and that's what we've done. Amazing what wonderful choices we have.
What's your go-to, Mitch, for that?
Well, thanks, Kathy. And it's really interesting to hear everybody's perspective here. So for me, I do look at a lot of different factors when I'm treating a patient with presbyopia. I mean, aside from the fact that we're obviously concerned about whether or not they may have discussing the potentials for night vision, glare and halos, things like that, I kind of want to know from the patient's perspective what type of near work they do. Do they actually where do they like to hold things? Do they hold things really close? Or are they basically holding things at arm's length? Are they predominantly just really looking at their phone and iPads and computers? Or do they sit and read print? I mean, those are real factors in the decision-making process as far as what I'm going to talk to a patient about. But those aren't the only factors. Yeah.
Do you use sorry to interrupt you, but do you use a questionnaire to kind of get to that ahead of speaking to the patient, or is that all just part of your conversation?
We do. So we actually have Veracity, and so Veracity has a built-in questionnaire that every single pre-op actually goes through the questionnaire that we have in Veracity. So it kind of gives us a starting point to discuss with patients. But one thing again with questionnaires, I don't have it saying where do you hold things. I kind of want a patient to show me where they hold things. So that's a major factor. Obviously, our questionnaires discuss, do you care about if you're going to have glare and halos at night? Is it more important to see, distance and intermediate, or do you really, really want to have distance, intermediate, and near? I mean, those are all things that the questionnaires help us with, but they don't answer all of our questions, obviously. And they don't tell us some of the anatomical considerations that are important. And for me, having been a proponent of really understanding the anatomy of the eye and understanding the visual pathway, some of the things I've identified over the last 10 years or so as we've been involved with presbyopia surgery has been really looking at not only just what a patient wants to be able to see, but we look at other factors like their line of sight. We look at we use an eye trace. The eye trace allows us to measure what's called angle alpha D, which is basically a difference between the patient's line of sight and the center of the eye, i.e. where the lens is going to wind up after surgery. I think what a lot of us experienced early when we started presbyopic surgery was we would place a lens where we thought the patient's line of sight is by asking them to look at looking at the light and basically lining up based on the visual axis. But post-operatively, what our experience was that those lenses don't always wind up at that spot, and we have decentrations, and so patients wind up looking not through the center of the lens. So I've been very particular when I look at patients, and it's more common in patients that start off as hyperopes. They tend to have a larger angle kappa, and several ways that people can look at that if they don't have an eye trace. If you have an IOL Master 700, you can just look at the printouts and see, if the patient's, line of sight is close to the nasal aspect of the pupil. That's really a telltale sign for, hey, watch out kind of thing. So it's looking at all those factors for me in my decision-making process. That's kind of helping to avoid having problems or unhappy patients post-operatively.
So let's say all of those factors, a patient, tells you they like to hold things close, they want to see things at distance, they're really active, they want all the ranges of vision that they can reasonably have. They have a healthy eye, their line of sight and the center of their eye all lines up perfectly on their preoperative assessment and everything looks good. So in that case, what's your go-to technology? How do you approach those patients?
My go-to technology in the dominant eye right now is actually the Symphony OptiBlue lens. So it's a J&J lens. It's the Symphony lens was a good lens before, but we had a lot of complaints about glare and halos or spider webs. things like that for patients, and then not necessarily getting all the near demand that we were expecting. However, they've made some modifications to the lens. So they've kind of revamped their whole platform and put a violet blocker that's really helped to eliminate those complaints that we were having previously with glare, halos, spider webs. They've just disappeared completely. In addition, they've modified the haptics. So one of the issues that we had previously was the toric patients, where the lenses were rotating on us, and patients were looking good at day one, but they would come back 3 months later and all of a sudden their vision had deteriorated and the lens rotated 40 degrees. That's not happening anymore. These lenses, the new haptic design has really eliminated that process. And what I like about the lens, relative to the trifocal lenses, which I still do use, and we'll talk about that in a minute. What I like about the lens is really there's very little light loss at nighttime, so that patients have high contrast, they have good night vision, which I think is something we have to counsel our patients when we use trifocal lenses about, is that there definitely are some issues with night vision and loss of light. When we look at the Panoptix lens, which I also use, I am a little bit more cautious about the patients who are driving at nighttime with the lens. It's not that I don't use it; I definitely do use it, but I tend to kind of like when I was doing multifocals, I tend to prefer those lenses for patients that are maybe not necessarily doing as much night driving, but do have this near demand where they really like to hold things a little bit closer and want that kind of seamless vision from 14 inches, through the range of vision. So with the Symphony lens, what I do is I will place that in their dominant eye and see where they wind up postoperatively. The majority of patients are actually very, very happy with the range of vision that they achieve with that lens. However, if they don't achieve the range that they're desiring in their non-dominant eye, I still now have options for giving them more near. So I can actually go to either the sort of medium ad Technis multifocal lens, or I'll even consider a Synergy lens in their non-dominant eye. I think one of my discouraging points with the Synergy lens was just the real tight landing zone that the lens has, and if you're off by plus or minus a quarter, it's a very unforgiving lens, and the patients are complaining. However, as a second eye or non-dominant eye lens, where I have the experience from the first eye and I can actually fine tune based on that experience and really now be able to account for effective lens position a little bit more accurately, I will then go to a Synergy in the second eye, which will give them that same range. And it has the same, it's built on the same platform. It's kind of similar to I would say a lot of my colleagues that are on the panel here who are using Vivity and Panoptix in the same kind of mix. But for me, I just find that the near results are better with Symphony than Vivity in my hands anyways. And then I don't really want to kind of mix platforms. I kind of want to stay within the same platform if I'm going to look for more near. And so I can go with Synergy or the Technis multifocal, one or the other.
Do you ever offset Symphony a little bit to give you a little more near?
Yeah, so if they're generally happy, I mean, I don't want to offset too much, but the dominant eye, definitely go plano to minus a quarter. But for the non-dominant eye, I will, just like I will with certain monofocal lenses, I'll go minus a quarter to minus a half. I mean, I think with any of these lenses, if we're off more than minus a, the nice thing is this does have a little bit bigger sweet spot, so you can go to minus a half. But just like everything else, I think if you try to push it too far, you go to minus three quarters, you're not going to be happy. I mean, and again, I've experienced that with Vivity as well. So, I think that the range is really, we can push it minus a quarter, minus a half. And I'll be honest with you, I have a lot of patients when I do that are 20/20 distance and J1. Those patients I will consider Panoptix.
Yeah, and I totally agree too that the light adjustable lens has been really a game changer, especially in patients where we can't get good biometry preoperatively, or maybe they've had more complicated corneal surgery in the past, or they're RK. And it's been really great. And I'm I've been impressed with what range of near vision they get while they refract to very little myopia. So they definitely get an EDOF-like effect with the treatment. And it's, it's a lot more work, I find, because there is that postoperative period where you feel like, oh, we're done, and you're not. But the end result is a lot of precision and really fine tuning the result, walking the patient through it so that they get to see, where they are currently, and you can make adjustments for the future.
I've been very happy with LAL. I think I'm getting more comfortable, especially since they added the Active Shield last summer. I mean, one of the issues that we had early were some late changes with the lens, but since the development of Active Shield, or the release of Active Shield, we've had a great experience. Patients, with comfort, I can say patients don't have to wear the UV glasses all the time. I do have them wear them outdoors, in sunny situations, but indoors, I don't ask them to wear them, and I don't ask them to wear them 24/7. What I find with the LAL, I'm using it in several scenarios more regularly. So patients who've done previous monovision, I think it's a great technology because we can play with it, different from monofocal IOLs. I think in my post-refractive patients, when they're asking for accuracy and effectiveness, I say, this is the best lens. I said, just like when you had LASIK, this is the lens that I can correct, as accurately as possible and with better results than I can do with any other lens. So I think that's another place. I mean, I'm really having a great experience with it with RK patients, post-RK patients, but definitely with my post-LASIK patients as well. And then any patients that don't want night vision aberrations, we do have, with the negative spherical aberration, or what we're doing with these lenses is we're actually steepening the center of the lens traditionally. So we're getting a little bit of a multifocal effect with that on these lenses. And that's how patients get more range of vision. And, and I think that's been a really great experience for patients.
You did kind of touch on this, Steve, too, having other options that help with more complicated patients. So I know we now have on the horizon the small aperture IOL, like the IC8. Any thoughts on that? Anybody would like to comment on where they think that's going to fit in their practice?
I'm super excited about it for my patients with previous RK, or I have a large thriving cornea practice, and I'd say there's a number of patients who could absolutely benefit from the technology who have these aberrated corneas. I know that the studies were done with so-called normal patients, and they get also a EDOF effect there as well. However, where I see it most useful is with the more aberrated corneas.
I agree with Audrey. I'm probably going to start there as well with my aberrated corneas, post-RK, keratoconus, corneal scars. I've seen a lot of good data from our colleagues overseas showing pretty significant improvement in the best corrected vision after the IC8 lens because they're decreasing those higher order aberrations. But it is a nice lens because you kind of get to hit two birds with one stone. You get the improvement of the image quality in these aberrated corneas, but you also get that extended depth of focus. And so it's sort of like you're offering almost a presbyopia correction to these aberrated eyes that you otherwise would not have ever been able to offer unless you did full-on monovision. And I know a lot of colleagues have been using it for that purpose as well. And I think they will place it either in both eyes or perhaps only the non-dominant eye and aim a little bit mini mono, like a 1 1/4 or so in the non-dominant eye. I have heard that you can get some dimness if you place it in both eyes. So that is one thing that I'm going to look forward to counseling my patients on.
So interestingly enough, I've had several patients that have been waiting for the lens, and we keep getting told it's going to be here now. Hopefully, it looks like the fall. But I had a patient recently that couldn't wait. She was post-RK with some irregularities, and she actually went to Europe to one of our colleagues and wound up having surgery. And they actually put an IC8 in one eye and an LAL in the other eye. And it is. I was actually kind of impressed with the results in the IC8. So I actually have a patient with an IC8, not done by me, but I do have her, and I'm monitoring her, and it's really amazing at the effect that it can have in reducing aberrations in patients that have irregular corneas, as well as extending depth of focus by having that small aperture. So I do see this as a lens that's going to find a place in my practice for sure, because I do see a lot of irregular corneas and things like that.
Yeah, I think that one of the interesting things to me is when we have a refractive target that's labile, like a post-RK patient, is that you do get this refractive forgiveness, both for up to a diopter and a quarter of astigmatism and even a diopter of refractive error on either side of plano. And so if you think that things are moving throughout the day a little bit, and that's a moving target, something that has that added forgiveness throughout the day while still giving some increase in depth of focus with a little bit of, maybe a little bit of myopic offset to begin with. I think there can't be a better solution for patients who have something that's moving throughout the day, like an RK patient.
And, and even the patients that don't have irregular corneas, I think that extended depth of field that the lens offers may be a choice for the patients that we don't necessarily want to do a lot of monovision, but by using this lens, we can get them more range of vision, just targeting distance or slightly off distance, without having to create a lot of night vision issues.
Yeah, and the small aperture also gives some refractive forgiveness too, both for the spherical
It
equivalent and
corrects
residual
astigmatism.
astigmatism.
Yeah,
Yeah,
absolutely.
which is really a cool aspect of it too. In the patient, since you're one unique amongst us, Mitch, and having experience with this with your patient, did the patient notice that there was some dimming on the side with the IC8 compared to their LAL eye, or no comment on that?
Well, so it's kind of early. So the patient recently had surgery, and I still actually I'm going to have to do the light adjustments for the patient on the eye that had the LAL. So she's not seeing as well. So she's actually seeing better with the IC8 lens right now than the LAL lens, and she's just so happy because of the fact that there was really very limited options for her. I mean, there was nothing that was going to give her perfect vision, and really her goal was to be able to drive, and she absolutely does not want to wear contact lenses. So even though she doesn't have a perfect refraction, it's really eliminated way. She had, I'm going to say, 4 to 7 diopters of astigmatism in her corneas. That IC8 lens is manifesting right now at plus a quarter, minus 125, and she's very happy with that. It's not your traditional thought process, necessarily. I mean, these patients that really have irregular corneas, if you can eliminate the majority of their aberration, most of them are going to be happy because you wouldn't have achieved it with another lens.
Yeah, absolutely. And might be able to get them out of something else they might need, like a scleral lens or other solutions. Any pointers, and Brian, I'm going to ask you, do you have any pointers for surgeons who haven't really jumped in to presbyopia correcting IOLs? Anything you would say that might be, maybe an easier place to start, or reassurance that they have with today's technology?
We have so many options available to us, and one of those options is going to work for at least somebody. So having lenses like the Vivity lens that are non-diffractive, so you can avoid the conversation of glare and halos, or if your practice has access to the light adjustable lens, these lenses are really low-hanging fruit because they're almost a lens you could put in just about anybody. Now, it's harder to jump into the world of diffractive technology because you do need to have great preoperative and postoperative support for these patients. You need to have the ability to fine tune them. So if you don't have that ability, start simpler. Start with the Vivity lens and start doing a little bit of mini monovision. The patients that you otherwise would have done a full monovision, do a mini monovision with the Vivity. It's really quite easy and quite rewarding to get involved with these types of lenses.
Number one, ocular surface management is a huge component of all this. So I think that you have to, if you want to be successful with presbyopic lenses, the first thing you have to do is make sure that the ocular surface looks good before you do surgery. That kind of goes without saying. And I think, unfortunately, a lot of people don't look at the ocular surface critically beforehand. So just staining with fluorescein, looking at tear film function, those are kind of the critical things that we do to even make a decision. You want to do that before pre-op. So you want to do that and assess the patient, and not be afraid to tell a patient that is coming in, like for a pre-op visit, and you really is motivated. I think it's important to kind of sometimes delay surgery and make sure that we resolve that problem first. To keep happy patients, because obviously the concern is you don't want unhappy patients, and when you have unhappy patients, they take more chair time. The staff starts to get discouraged, and the doctor gets discouraged, and may sometimes think it's the technology. It's not necessarily the technology. I think for those that haven't gotten started yet, starting with extended depth of focus lenses is definitely a way to go. You have larger sweet spot with the extended depth of focus lenses, less visual aberration. So I think that's a fair way to get your feet wet as you move into the presbyopic realm, I would say. For trifocal lenses, and the multifocal lenses, I definitely think that you want to have experience, and you have to know your refractive results with your lenses. You have to be consistent, and you also have to be ready to enhance patients as necessary. So that's got to be a part of it.
Yes. Yeah, I think that those are good pearls, and I would encourage people as well to really try it, because I have to say my presbyopia correcting IOL patients are really some of my happiest patients. They have their vision back, youthful vision, as I've heard patients even today saying, that they never expected. They didn't think that that would be a possibility later in their life. And I feel like we give this great gift to patients that is something that is an additive thing in their years when they thought that there was no solution such as that. So definitely give it a try. So we're going to shift gears, and instead of talking about drops or IOLs, what we're going to talk about now is LVC, laser vision correction. We have a number of different possibilities, from LASIK to PRK to SMILE. And so how are you deciding what the best option is for patients? And first of all, I know we each offer different things. So Mitch, what are you offering patients for laser vision correction?
So I don't have SMILE as an option for my patients currently. I do LASIK and PRK. And my decisions for LASIK and PRK really, I'm going to say primarily are, based on is the patient pseudophakic or phakic? So, I do actually do some pseudophakic presbyopia correction with LASIK for those patients that have had prior surgery and want to have some near. So we certainly have done that, but those patients I'll tend to do a little bit more PRK. For LASIK, my LASIK range for doing presbyopia is really going to be up to about 55 years old. So the 40 to 55-year-olds, we do talk to them a little bit about extending their range and doing some presbyopia or near correction in one eye to enhance their overall range of vision and really reduce their need for glasses.
So we have had corneal inlays in the past, and we don't really have those available anymore, but there are allogenic inlays that are on the horizon and look really promising, I think. But what are your thoughts on corneal inlays in the future?
So I was actually involved with a lot of the early technology with corneal inlays. I actually did a lot of the original animal work for revision optics, which we had the raindrop lens, and it was exciting technology early on. Unfortunately, what happened with the lenses is that because it was a synthetic lens, the cornea just doesn't like synthetic objects. And the lens required having some it did have a water content, and unfortunately, the endothelium wants to pull water through the lens, through the cornea. So the lenses tended to dehydrate, and you would get some rolling and some haze along the edges. So unfortunately, the technology failed. However, for those patients that actually still have the lenses, they definitely were happy. It was really interesting to see the effects of having that central steepening of the cornea and their ability to develop, near vision, in the J1, J2 range. And so I'm actually kind of I've been waiting to see the Allotech product come to market, because I do think that the concept works. We know that it works. It's reversible, and using natural human tissue, the likelihood of having a problem is being reduced. So I'm very optimistic about the ability to offer that again as an option for patients.
Any thoughts on new technologies that may be available in the future, such as laser to the sclera? Yeah, what are your thoughts?
So again, I was involved early on with the scleral expansion devices as well, which was something that we did, 20 something years ago. And I have some patients that swear by it, so expanding the space around the lens, I think, is a potential option. Unfortunately, eventually the lens gets too thick to work, so it's something that can, that can offer a period of time the patients will be able to extend their length of time without glasses per se. I think kind of the same principles as lens softening drops that will become available hopefully as well. The scleral, but I think laser scleral treatment will have a place probably in the in the kind of mid to moderate presbyopes, but probably not so much in the later presbyopes.
So we only have a few more minutes, and I just wanted to talk a little bit about, the lifetime of the patient with presbyopia. So I think that, at least in my thinking today, I try to think of what is the series of progression of disease and maybe the series of treatments that I can fit together, like unique puzzle based on the individual patient sitting there in front of me, their expectations, their ocular health, their age at the first time they present, and all the tools that we have. So any thoughts on for presbyopia with all the strategies we have, from LASIK to drops to refractive lens exchange to cataract surgery to enhancement of cataract surgery? What are your thoughts now as you look at the lifetime view of the patient? And I'm going to have Steve start with that.
Well, presbyopia is, it's sort of like our most common thing that we will face to fix. Everybody will have it. And it's really where we have perhaps our least options that work as well as what we can do with LASIK. We don't get LASIK results. We don't get regular cataract results. So it's a bit of a challenge. Now we have so many more new treatments. It's wonderful that I think perhaps for the first time, we can span the experience of a patient going through presbyopia. If the key is a bridge procedure, the key is to avoid exchanges or explants. And the key is to whatever we do in the first one or two, I'm thinking 3 procedures, whatever we do in the first 1 or 2 procedures, to have it be as compatible as possible with what we're going to do in the future.
Yeah, fit them all together with the big picture in mind, right?
Right.
So is there anything on the horizon? I know you were saying maybe presbyopia drops isn't going to be the perfect bridge for you. Is there something else in development or on the horizon that you think might fill that role of a bridge treatment better or differently than drops?
There's some candidates. I mean, one candidate is obvious, aggressive RLE, right?
Mm-hmm.
Just bringing that, which has good results, that procedure down into to meet LASIK. I mean, LASIK monovision is a wonderful procedure. Multifocal LASIK is not. So that's one effect. A inlay that is biocompatible is another option. I mean, the inlays that we had that passed the FDA didn't fail because of their results visually. They failed because of their biocompatibility.
Mm-hmm.
A drop, and this is not going to happen, but a very long acting drop. So we may wind up, it looks like 3 procedures, but over lifetime, maybe we'll wind up with stretching LASIK and stretching LASIK up and stretching RLE down.
How about Audrey? What about you as you're looking at your patient selection right now? How are you fitting the puzzles together, and what would be, your thoughts on the future?
I think that a lot of it really is some education, at least for those sort of pre-presbyopic / early presbyopic myopes that I'm doing SMILE or LASIK on. And trying to educate them and then offering them a presbyopic drop. I mean, as we discussed, it's not perfect, but at least for the moment, as Steve said, we're trying to increase the range of your laser vision correction, SMILE or LASIK, and then decrease maybe where you're going to be starting your refractive lens exchange options. Of course, we want to be cognizant of some of the other issues, such as retinal detachment and high myopes. And so for the RLE group, you do want to calculate that as a risk, as well as some potential, I would say, mild concern about whether some of these presbyopic drops that have pilocarpine in it can also potentiate that. Again, not proven, just a few case reports, and unclear whether this is related. But I think it's wise just to give pause to that as we are pushing the limits of both, perhaps.
Those are great points, that nothing comes without potential risks and benefits that we weigh for each patient based on their individual needs and their individual eye health as well. So you never lose sight of that either. How about Brian? What's your approach with the spectrum of options, and anything you're excited about in the future?
I definitely start the journey trying to see if the patient who's coming to me for laser vision correction at 39, 40, 41, I try and see if they'll tolerate a little tiny bit of an offset. And if they can tolerate even just the -50 in the non-dominant eye, or even up to -75 at age 40, I'll try and push them there, because I know they'll be happier as long as possible. While I love RLE, I think that these are some of the happiest patients I have. I also have a portion of my practice devoted to secondary IOLs. And every time I'm doing an RLE on somebody who's a little too young or a little on the younger side, I think about the longevity of that lens in the eye. And I think, and I hope, the majority of those lenses will stay put for a lifetime. But I also see patients 20, 30 years after cataract surgery and their lens is dangling. So I worry about that a little bit. So having a bridge to get them to the point where they are ready for officially cataract surgery would be really nice. And I don't know what that bridge looks like. And maybe it is pharmacologic, but in a sustained drug delivery form. Perhaps we enter the world of intracameral administration of a long-term miotic, or intracanalicular administration of that, or even just a contact lens. So I think that those things are all possibilities as the world of sustained drug delivery continues. And I hope that in the future, you and I, Kathy, are not handling a million dislocated IOLs.
When you were saying that, I was just thinking about my clinic that's always full of dislocated IOLs too. We need to find better solutions for them. We'll work on that.
One nice thing is the presbyopic drops that we now have available to us is going to sort of pre-identify patients that want to have refractive IOLs. So we're conditioning them already. If they're willing to spend the money, $1,000 a year on eye drops, they're likely willing to have refractive lens correction as well, or going to want refractive lens correction as well, because they've already identified themselves as it's important to them to not wear glasses. So, I think starting at that early presbyope and offering, presbyopic eye drops is the first place to start, because, that's going to it's going to, number one, build, it's going to build part of your practice that's looking for presbyopia correction early. And there may not, at this point, we may just not have the right presbyopic treatment for them. And so this kind of delays that that need. But certainly as things like inlays become available where we don't have to be as aggressive and go into the inside the eye, I think that that's certainly going to be the starting point. Presbyopic inlays and laser, like you said, is going to be the next phase. It's going to be for the early, the presbyopes that are 45 to 55 that don't really have lens changes. I'm always hesitant to do refractive lensectomy, certainly in myopes or patients that haven't had prior PVDs or we don't see any vitreous attachment, where we certainly could potentially cause a problem if we operate on them too early. So I think that that's going to be kind of the second range for patients, and then then obviously we start to get into our lens-based procedures, I think, for our patients.
That's great. And I think the presbyopia is an opportunity to create a relationship early on with patients who we may not have seen prior, to let them know that we're there listening, caring about their needs, coming up with solutions that work for them for their different phases of life. And then hopefully, encouraging them, their family members and friends, to become future patients in the practice.
And then lastly, something we didn't even talk about, but is also on the horizon, is the ability to adjust lenses that are already in the eye. So refractive lens indexing. I think that that's going to be something. We don't have that capacity right now, but I think 5-10 years from now, I think we will see that as part of the armamentarium that we have to offer patients.
Yeah, I'm excited for that as well. So, and last but very much not least, Dagny, tell us your approach and what you're excited about.
Yeah, I see myself as the patient's presbyopia physician over their lifetime, or at least once presbyopia onsets. Because I'm not their Vuity doctor, I'm not their PanOptics doctor, I really am their presbyopia physician, and I'm choosing the best technologies for them at that period of their life. So early on, I think we're all trying to preserve their lens. So if their lens has partial accommodation, we don't want to replace it. We want to keep it there. And I think there are a lot of modalities that we have now that allow us to prolong the patient's natural lens. So for example, presbyopia drops, the corneal inlays with allergenic options, as well as even a phakic IOL that perhaps has some extended depth of focus or some sort of presbyopia correcting properties. I'm very excited about that. And even within the presbyopia drops category, I think there's a lot of innovation still to be done there. We've only seen one candidate so far, Vuity, of the many candidates coming down the line, some of which are also pilocarpine based and some of which also work on the pupil but are not pilocarpine based, and then some which even work on the lens itself and softening the lens. So I'm very excited to see what will become of those options and how we can help those patients. I do a large amount of RLEs in my practice and they're very happy, but I always try to preserve their natural lens because nothing beats Mother Nature, whenever possible.
We all want to be 20 again with a perfect lens, right? I tell
exactly. Exactly. So I think we're acting as their bridge to more definitive lens-based surgery. I think, it's nice that we're practicing in this time where there are more options before that more permanent solution.
Well, this was a great discussion, and I think we all learned something that we can take back to our clinics and improve the way that we approach presbyopia correction. I want to really personally thank everybody on the panel: Brian Schaefer, Mitch Schultz, Steve Slade, Audrey Talley-Rostov, and Dagny Zhu for sharing their thoughts with us today. Thank you all.
For more shows like the one you just listened to, check out the podcast channel on itube.net.